Okay, so welcome to our Mentor Spotlight, a live conversation to explore the role of mentorship in developing the professional and personal identity of physicians. I'm your host, Marielle Bugayong, and I'm so excited to introduce Dr. Rani Nandiwada. Dr. Nandiwada is a clinician educator at the Penn Center for Primary Care. She is the director of the Medical Education and Leadership track, as well as the course director for the Outpatient Medicine Externship and for the Foundations in Healthcare Systems first year medical student curriculum. Rani is also a member of the Society of General Internal Medicine's Education Committee and former co chair of the EBM subcommittee. She focuses on building the primary care pipeline and teaching skills that empower trainees to improve healthcare delivery and patient outcomes. Also, fun little fact, we both share a love for watching horrible romantic comedies with guaranteed happy endings and cracking corny jokes that no one else thinks are funny. Welcome, Rani.
Hello, everybody. So happy to be here today. I have a guest with me here who I promise could come and say at least hi. This is my little mentor, and I think as I think about my own personal and professional identity, one of the most important things that helps guide me with everything that I do is to be unabashedly me and to teach her to be unabashedly her. So, Sita, do you want to say hi to everybody?
Hello.
All right. And then, Sita, we're going to have you answer one question and then you need to go to bed.
Okay.
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 So, I'm going to do our mistake question. So, are mistakes bad things, Sita?
No.
Okay. And why are mistakes not bad things?
Because sometimes you can learn them from them, and sometimes you need them.
Yeah, I think that's really important. Sometimes you need to make mistakes, right? And they make you a better, stronger person, right?
Oh, and like the time we made scones.
Yes, we have spills, we make mistakes, and that's okay, right? All right, off to bed you go. Love you. All right.
Thank you for those very wise words, Sita, and thank you for the introduction, Rani.
All right. I
Uh,
will be
so-
unicorn now. I may be the first unicorn mentor that you've had on here today.
well, I would say a very iconic one.
All right, off you go. Yes, that way. Love you. Go, go, go. Daddy's waiting for you. Sita, go. Okay.
You have to get over.
Okay.
I'm gonna try not to touch the ground.
Okay, you go do that. Challenge yourself.
All right. So, to start off, tell us a bit more about yourself. What inspired you to pursue a career in medicine?
So, interestingly, when I was growing up, I had zero desire to be a doctor. Part of it was both of my parents. Well, my mom is a physician, my dad was a physician. Um, and I saw some of the wonderful things that being a doctor was, but I also felt what it was like to be a kid of a two physician family, which was hard, right? Like growing up, you're like at the mall, you want to hang out, mom's on call, you're like waiting in the hospital parking lot while someone's like running in, and you're just like, what is happening right now? Um, and my dad actually had delayed his training. He was a pharmacist in India, came here, went to medical school in Mexico, while my mom was a resident in Mississippi, in Louisiana, finishing medical school. And so when I was young, he was still in residency and he was a GI fellow when I was like in elementary school. So he was super busy all the time. And I just felt this like, my parents are busy all the time. I want nothing to do with this. But I think when you live with physicians all the time, you see how hard it is, but that creep of the beauty of it and the impact that they have on people is something that you can't escape. And I think I was running from it for a long time. And then I went to business school for college too. I was in a business magnet program in high school. I went to business school at Stern for NYU at NYU. Um, and then in my second year of college, all of a sudden I'm like, I want more. And I think I blame my parents for it because it was there, the good and the bad and the ugly, and the good overcame. And I was like, I see what they do. I see how my mom is a pediatrician is a part of her patient's life, about, how we would go and see them in the mall, and they would be so excited to see me and see her because it was like their doctor. And I'd be like, she's my mom. Uh, uh, and same thing with my dad. I saw that, like, yes, it was calls at night or late nights and, having to go in to scope someone, because there's an emergency, but the way that the families and his patients, that he cared so deeply, and that what he did mattered so much. Um, it affected me one way or another, whether I realized it or not. And I think seeing those experiences are truly what ended up pushing me in that direction. And I fought hard against it. And so maybe a little bit's in my blood. Um, and I think some of it was just when you're around it, um, it reflects on, I think, what I feel in my career today, right? There are so many hard parts about being a physician and being a mom and having a family. But in the end, what we do with our patients and those impacts, that impact it has on it, like, I hope Sita sees that. I hope she sees that, like, I'm run around like a crazy person sometimes. But in the end, it's because it's to help people, it's to be a part of their lives, to help them on this journey when they're at their most vulnerable times. Um, and I think that's really what inspired me to come this way. I know there's always lots of conversation about with doctors about, like, would you tell your kid to become a doctor too? Um, and I think we all struggle with that. I think that it's something that if you love what you're doing, and people, you have to love it to this degree where it's your patients literally are part of your family, and then it doesn't feel like work, right? And then it's okay, because you realize that there's this bigger picture, this bigger impact of what's going on, and it adds so much depth and meaning to what you do every day.
Yeah, absolutely. I think, that's really beautiful. And again, it's interesting to see how sort of what's salient to you when you're younger, as far as, how your parents um, having to prioritize a lot of things, versus what you see, the broader impact of what they're able to do through their professions, and how you want to be involved in that as well. That's really impactful, and that's really incredible. It reminds me also of my mom's own journey. She was a physician in the Philippines way back when, and it was, I guess I was little, but my mom told me that, one of the things that she recalled was that I used to sit in the little stool and watch her as she examines the patients. And she had her own practice, so she would see patients of all different generations. And so it's nice to, as you framed it, realize that these patients can also become kind of part of your extended family, being so close and so involved in their lives, and being able to stay in touch through the years, see how their health is going, but also see more broadly how things are progressing. So thank you for that. So the next question is, how would you describe a good doctor?
So I think that's such a hard question in so many ways. And I think, good in itself is a hard word, right? Because there's so many aspects of what does good mean when you're a doctor. I think that so many of the doctors that I admire and respect are, one, because of their authenticity, right? That they're true to themselves and who they are, even as they are a physician. Um, and that shines through. And they also have this humbleness and humility about them. And that the driving force is that they see someone in need, and whatever it is, they will do what needs to happen to to help that person, to be there with them, to walk with them, to support them. And sometimes that comes in the arena of really great diagnostician or clinical reasoning, which you have to have as a doctor, right? If you can't do that, then you're not able to help people, right? And so I think staying on top of your clinical reasoning, being aware of your own biases, being aware of, and I think this is the hardest part, of being okay with not knowing something and knowing what you don't know, right? That's one of the most important things about being a good doctor, right? The way that data and things are changing all the time, like memorizing a bunch of facts, that doesn't make you a good doctor. That makes you a good person for memorizing things. But having the insight to understand and to accept that I'm still learning all the time, I don't know everything, and that I am a better doctor because I can say that, because it means that I'm going to push myself to read more, to look more, to think more, to work harder. That's the drive that has to never die. And I think that's what makes a really great doctor. It's being true to who you are as a person. It's letting that shine through with your interactions with your patients. And then it's also pushing yourself to know that I'm always learning, and that's part of my job.
Yeah. And I think, again, as you've brought up, authenticity and also that strive to continue to be a lifelong learner, as our elementary school teachers would hope that we become.
Yeah.
Yeah, I agree that those are really key points to being a good doctor, and how good itself is quite subjective, but in this case also very complex. And as you've brought up, how it's not just that you have the diagnostic knowledge, but that you're able to meld that with other parts of just the human interactions and such. That all encompasses being a good doctor.
I think the other part I would add to that, and I think this is part of why my interest in health
Mhm.
system science is even there, is that you can be the smartest person in the room, you can be great with your patient, but if you can't figure out how to get them what they need, you've still essentially done not that much as a doctor, right? It all needs to come together as a whole picture to deliver care, and so it's all parts of it. It's the diagnosis, it's the personal interaction, but then it's also the delivery of the healthcare. And I think so many times we forget about that last component, which is such a complex, loaded component of being a good doctor, right? That's the social determinants of health of a neighborhood, the history, the social justice of your patient population, your community. It's their social risk factors. It's what resources it has. It's understanding that, like, a lot of my patients in West Philly are more worried about like housing and food than they are about what their A1C is, and being in tune with that, and meeting the patient where they're at, right? Because without all three components, you can't you can't change health outcomes, you can't support patients unless you think you hit that trifecta.
For sure. And me having a background in public health, again, I absolutely agree with what you're saying. And so how, important social determinants are to a patient's health, and how truthfully, as you've probably seen in your practice, when they come in for the visit, they're not just thinking about these, biological markers, they're thinking about so many other things related to their broader circumstance. And so touching a bit more on this topic of health systems, how does that, look like? How do you consider or adapt that health systems framework when you're interacting with your patients?
I think it's a little almost part of every moment, right? Like the patient comes in, I know who they are. If it's one of my long-term patients, I mean, that's part of why I love being a primary care doctor and a generalist, is like my patients are mine. I have a very strong sense of ownership of my patients, and they know it. And I think that's why we all love each. It's like mutual love, right? I always tell them, I'm like, I'm going to be in a pain in your butt because I care. And it'd be easy for me to just say, okay, that's fine, do whatever you want. It's a lot harder for me to advocate and fight for you, even though you don't want this. Mainly about flu shots currently. That's a lot of my flu shot conversations right now. But I think it comes into everything. It's me knowing who they are. It's knowing what they're going through in their life, right? Um, I help run our Suboxone clinic with the residents as well. And so for that patient population, it's every moment, right? It's knowing what their barriers to care are, their housing stability, what their triggers are and from a psychosocial factor, but it's also realizing what insurance they have, what meds I can get them, which team members I need to have them interact with, what's going to destabilize one of my patients who's been doing really well in recovery, right? COVID has been, I mean, insanity when it comes to some of our patient populations, right? We had some patients who were doing so well, right? Like we have one of my favorite patients, and when he's great, right? And if you look at this from a health system standpoint, right? Like when he has housing and he has a job and he has mental health care that he can engage in and he uses his Suboxone, he does great. Like he is the kindest, nicest, most wonderful person, and it just warms your heart. And then when things go bad, right? Like his health outcomes are not determined by me giving him a Suboxone prescription or not. He goes into relapse when his housing destabilizes, right? When he lost his job and then couldn't afford housing and then couldn't find a recovery house to stay in, that's when he destabilized, right? That's when he's going and overusing the emergency room, getting hospitalized multiple times for all kinds of things. because those system resources weren't there to support him, right? And you can look at that in so many systems ways, whether it's from, you know, a larger public health standpoint, from a policy standpoint, from, you know, just what resources we were able to provide. And there's only so much I can do from my perspective, but I have to think about all of that when I'm caring for him. It's not like, oh, he just chose not to do his Suboxone, right? Because I know when he does it, he does great. He knows when he does it, he does great. And then it's it's getting my social worker, it's getting my certified recovery specialist involved in his care. It's, you know, him knowing that even if he doesn't have a home, and even if he didn't take his Suboxone, and even if he did use heroin again, that he's welcome in our office every single week, and we're going to be there for him while he works through the rest of the system.
You've definitely spoken to certainly the challenges of helping patients and, you know, really trying to juggle so much of what they're going through, but also recognizing some of your limitations in that. So thank you for that great work, and thank you for that story. I guess transitioning a bit as well, I sort of wonder now, how are you, you know, able to convey this to, let's say, the trainees and the medical students that you mentor, for the residents as well?
So I think this is always challenging. I think the preclinical students get it, but don't fully get it, right? They're preclinical, so they understand, and their focus is really on, like, I need to know the medications and the pharmacology and the physiology, which you do, you 100% do. But I think it's hard for them to understand that, right? So that's the first part. They're learning the history, they're learning the diagnostic part, right? They're learning the physiology, they're learning what's happening in the body. But then that third part, which is now, how do I get that care to the patient, is a hard one when you're preclinical, because you don't even know what the system looks like, right? You don't know what it is to be on a hospital floor. You don't know what discharge looks like. You're thinking about, like, oh, why won't insurance pay for this? Why is the hospital looking at these quality metrics and not seeing that bigger picture, which is really hard to see when you're not clinical. It's even hard for the residents sometimes to see, because I think we shelter them so much from this. Being like, you're going to learn this eventually, right? Like, oh, we're protecting you from the system. I think that's a double-edged sword, right? In protecting them from the system, all of a sudden they graduate and no one has actually taught them what to do with the system, right? Like, you know, we've been pushing more quality metrics, more panel management, more population health, but then we still say the residents and the medical students, like, this is not the priority, right? Because they have too many other things going on. But then when they go out into practice, like, who's there doing that with them, right? Who is sitting there and coaching them through this in a way, if it's not intentionally done during training? And I think that is a really big challenge, especially if you talk to junior faculty, right? The moment their first job, they're out, whether it's you're a subspecialist or you're in, you know, general medicine, or you're a hospitalist, the first time out, and it's like this overwhelming thing of, like, oh my gosh, billing really does matter. And I don't, like, I get that oh my gosh, I'm being held accountable for readmissions, and somebody's asking me about length of stay, and what about these metrics? And they hear them, but we still do protect them a lot from it. And so a lot of my efforts with the residents are trying to engage with the residents in co-creating curriculum that they feel is manageable, that doesn't feel like add-on. And that's really hard. And we've had lots of discussions about how it's so much easier to deal with a physical patient in front of you, or urgent messages and calls from a patient or a nurse, versus thinking about, look, this is my whole panel of patients. How am I going to outreach to them? What am I going to do, you know, to get their A1Cs under control? That one's like separate. It doesn't feel as pressing because somebody's not in front of you. And so I think it's really hard during training. But I think that if we don't start shifting training to incorporate more and more parts of it, then how do we create faculty who are doing it well? Right. And from the medical students, a lot of the work that we've been trying to do is more experiential for the senior medical students. So trying to get them out in the offices, thinking about how the health system works together. You know, how do you innovate? How do you get these leadership skills? What does population health and panel management look like in real life? And the first year course has been, I think, wonderful, but really challenging because of that, right? Like, how do you get buy-in, engage, and connect with preclinical students so this actually feels really important, right? And doesn't feel like add-on work when you're competing with a cardiology test, right? Um, unless this is on its own, the cardiology test is always going to win, because it's hard to see how this fits into the bigger picture sometimes.
Yeah. And it sounds like, again, a common thread through medical school is this, there's just so much information that students and trainees in general have to absorb all at once. And so it feels like there are a lot of competing interests. In that sense, I'm curious, how do you navigate that? How do you, convince students that, this is something important, this is something that we should take seriously and something that will be maybe not at the moment, but in the future, very relevant to their careers?
So that is the $1 million question, isn't it? I think that's what so many of us are trying to figure out right now. So Jed Gonzalo over at Penn State does a ton of health system science works, and we've had a lot of discussion about this. And I think sometimes it's a mix of you don't always know what you need, you only know what you want. And this might be something that is a need, not a want all the time. Um, and sometimes maybe that's okay, right? Like it's like making, well, my daughter actually likes broccoli, but in that same sense, like, convincing kids like, food that's good for them, even though they don't want to eat it, it's good for them, right? And they actually wrote the article calling health system science the broccoli of medical education, uh, which I thought was actually a really apt analogy, right? Like it's not always going to be loved, but it's still good for you in the long term. I think some of it is as time goes on, trainees and students will see how our role as physicians is starting to morph a bit, right? And so some of why I think there's this gap between role identity from the health system science part to trainees is because the identity or the role identity of a physician is filled with a lot of preconceived notions and assumptions from like when you were seeing your pediatrician, right? Or you're doing like a shadowing rotation and you see something very peripherally. And it's always in an exam room. It's always with a patient. And I mean, I think that's important. That's why I love being a doctor. It's because I adore my patients. I want to be with them. I want to spend time with them. I want to have those relationships. And those are some of the most rewarding parts. But I think it also stops us from thinking outside of the box, right? Like there's this one perception of the doctor where it's in the exam room, but then there's another perception of a doctor that I don't think people have fully formed yet, which is a doctor who's thinking about populations, a doctor who's thinking about communities, a doctor who's thinking about advocacy and policy and how that's going to impact health outcomes, right? And it's like broadening. I think in some sense, it's this very broadening definition of what a doctor is that trainees and, even like the high school students who want to be medical, want to go into the medical profession, and college students don't see, right? You see this one sliver of what it is. You go into medical school with this expectation of like, this is what I'm going to learn because this is what it means to be a doctor. And then we come and throw this other stuff in that you've never seen as part of a doctor's job. And you're like, this is not relevant to my life, right? Like, I don't need to know this. I need to know if you have heart failure, what do I give you to diurese you, right? Um, and then you don't realize that, yes, I could have you in the hospital and diurese you and do a great job. And then you go home and have no social support, no access to your medications, lost a prescription, have no access to like healthy food, and that you're just going to come right back to the hospital, right? Um, and when you bring this up to students, they're like, oh, that's common sense. They're like, that makes sense. Like, I don't need to be taught this. But then you actually do it in real life and realize, yeah, you do need to be taught this. Because it's not that easy, right? Things that it sounds simple. It sounds like you can think about it all, but it's so much more complex than that.
Yeah, certainly. And again, how do I impact? You've brought up so many key points here. Just again, looking at the broader picture, um, and even just as you've brought up this transformation of what medicine is and what's expected for a doctor, and what we should expect from medical students and trainees, and how to prioritize all of that. It really is just like kind of like the elephant in the room that we have to think more on this health systems. Um, with this health systems framework, and yet it's gradually happening. But
No,
yeah,
so like the AMA has put out many statements at this point saying that they think this should be the third pillar. The problem is you can say it's a third pillar, but if you don't have engagement and buy-in from your students,
yeah,
it's a hard third pillar to push through.
mhm,
And I think we're all working on ways to make it applicable, make it feel relevant, and exciting to students across, the UME and GME spectrum. Because you can look at it as like, oh, this is boring, I don't want to do it, or you can look at it as like, I'm coming into here to help people, to help patients, and I can help one-on-one patients, and I'll always do that. But can I do more? right? And I think especially as there's more and more of mid-levels or advanced practice providers, and other disciplines who are coming into medicine and healthcare, you can look at it as a threat, right? Or you can look at it as like, okay, we're all overburdened. There's a lot to do. We can share things, but this also might give me the opportunity to think bigger, to think outside of the box, to innovate, to be different, to do something outside of the exam room that's going to impact patients and impact care in so many different ways, right?
And on this note of innovations, what's been an innovation that you've spearheaded or you've been involved in regarding medical training?
So I guess the question is, so regarding medical training, so one of the projects that we've been working on with the residents, and it's been an ongoing thing, has been with the Penn Center for Innovation. And some of this was like, how do we start shifting what our outpatient clinical experience is so it is a little more proactive, that it's not always what's right in front of you in the exam room? Because if you think about our traditional visits, right? Patient comes into the office, we see them, we take care of them, we write their prescriptions, we order labs, they all come back. We call the patient or send a letter reflecting back on the labs. We call that a lot of intervisit care, right? So after the exam room, like, what are you doing to kind of close that loop, to reach out to the patient afterwards, to make sure they know what's going on, that they got all their testing done. Um, and then the patient kind of disappears into the other 99% of their life that doesn't involve us. They go do their thing. And we forget about them and they forget about us, right? It's not out of any kind of malintent. It's life, right? And then we don't think about them again until we see them come up on our schedule, right? And if somebody doesn't schedule an appointment, who knows if you'll remember them, right? You have some who, because you're so worried, they're in the back of your mind and you're thinking about them constantly. But not everybody, because some people are just fine and some people are changing. And that's traditionally how we think about our patients, right? We see them, and once we see them, they're ours, and then we care for them in that moment. We give them our all, we worry about them, and then we forget for a while until they come back again. And so our goal was like, how do we shift this so you don't forget about your patient in between visits, right? Because you could probably do so much more if there were like small touches that felt manageable in between that versus waiting 3 months, 6 months, a year before they came in. And so with the Innovation Center, we actually started to try to develop some add-on tools to Epic to try to create more task management processes for the residents, to almost like wonder list things that they want to do with their patients in a reminder setting with dates that they could share. So in a way, create a sign out to each other that was portal, but also to create this working list of like, hey, I saw you. I'm going to put it on my. We called it the tickler because I told you I'm super corny, and so the idea is that it tickles you to remind you about something. And so for the tickler, we made it so it's actually a dot phrase that you just put in your note that automatically uploads onto a separate, what we call a whiteboard, where you can document all the tasks, the when, the how, the to. Some of it even, we have the ability to send it to certain staff members so that they can look at the same list and help triage it too. And the Innovation Center technology actually makes this whiteboard able to pull in information from Epic so you don't have to go back into the EMR. So trying to think about like, what can we do that's different? How can we create tools like this? Because I think some of MedEd innovation is curriculum, right? It's like, how do I teach this to you? Some of the part that I find most fascinating about MedEd is that half of it is what like the didactics and what you teach, but the other part is that immersive experience of the clinical time, right? And part of educational innovation is, how do I change that clinical experience or exposure that they have? How do we build that in so that they feel that it's different, that we're creating culture shift and change by, branding certain things. So Mark Shalby is our program director in the primary care program and has worked, and he's one of my mentors as well. And so we've worked a lot to think about like, how do you create some of this as a culture shift in the clinical experience versus just being didactics, right? Because didactics are there when didactics are kind of like a patient encounter, right? When you're there, you're in it, you got it, you learn something, you take away maybe one thing and then you forget about it, right? And if you have that bolus and you don't have a drip throughout and you don't have it integrated into the clinical experience, then the hidden curriculum there is that this was a 1 hour didactic, but it's not actually part of what your real life is going to look like day to day. I think some of the struggle here is that even as faculty, so many things are changing, right? The way that we work. And I don't know what my clinical environment is going to look in 10 years, right? It could be very different. One would hope it would look different in some sense, right? That we've moved forward and are trying to think about some of these bigger metrics and things, and how we as physicians can engage in it meaningfully. But how do you train people to work to aim to a clinical environment where you don't know what the destination is, right? Right? Like, we're driving somewhere. I think it's going to be a really great place if we all work together, right? But I don't know what it looks like. So some of it is like, how do you just create foundational skills that provide the flexibility to be able to thrive in whatever that environment is, right? And some of those are leadership skills, it's innovation skills. Some of it is project management skills, which, like, whoever thought you'd need that as a doctor, right? Some of it is thinking about social advocacy and like assessing communities and neighborhoods, and it's figuring out like what slice of all of this is going to be a part of that end destination that we're getting to.
Yeah. Again, I'm so inspired and so incredibly like just impressed by all of the work that you're doing and all of the thought and the passion that you're really putting into improving medical training, training this next generation of doctors. I feel like we could talk for another hour about all of this because it's really fascinating. But unfortunately, we do have to wrap up. So one last question for you. What is a piece of advice or some words of wisdom that you'd like to share with our current medical students and trainees?
So I think, once again, it's going to go back to being authentic to yourself. And I think it's important in so many ways. I know a lot of what we were talking about or supposed to be talking about is mentorship. And for me, the mentors who have meant the most to me and made me who I am are the ones who like loved me for me, who made me feel like it was okay that I'm this slightly ridiculous person who like thinks 10 years out and big picture versus everything else. And that I'm a little quirky, and they appreciated and accepted me for me and wanted me not to change who I am, but to support me in creating who I want to be. Right. And so I tell this to my residents all the time, whether you're in the exam room or when you're with other people, whether it's colleagues, faculty, it's so important to be true to yourself. Like, your patients want you to be authentic. They don't want you to be a robot. They don't want you to be a machine. Like, you're all doctors in here because you're wonderful, caring, thoughtful people. And if you have to pretend to be someone you're not all the time, you're going to fry, right? It's exhausting to try to not to be someone else, right? It's freeing to be who you are, and that's whoever it may be. You know, if you're, a little more serious and quiet, that's great. Own it. Be who you are. Let your patients own it and love you for who you are. Let your peers and your colleagues and your leadership love you for who you are, right? But if you have to go in and try to be someone you're not, it's not being authentic to you, and it'll come through to your patients. They'll feel that it's disingenuous, right? I go in, I hug my patients. I wish I could now, but I can't because it's COVID and it breaks my heart. Like, we high five. I make them pinky promise with me, right? But that's because that's who I am. And they know that I'm doing it because you get what you see, right? But I think they appreciate that. And I appreciate the fact that I can do that. So when my job every day is me getting to hang out with a bunch of really amazing people all day, right? Where I get to learn about their lives, and somewhere along there, hopefully I'm pushing their health in the right direction, so that they can have healthy, long lives, and then we can keep talking for even longer. And so that's what I think would be. It's just really be true to yourself and find mentors who are going to help you be true to yourself.
Yeah, thank you, Rani. Thank you so much for your insights, and thank you for being earnest and authentic throughout this interview. I really appreciate that. So this is a great conversation. Before we go, I want to remind you all that this was brought to you by Ars Medica. We are a nonprofit organization dedicated to nurturing the personal and professional growth of medical students and physicians. Our online community brings together doctors, residents, and medical students to inspire and support each other in our journey toward a meaningful practice of medicine. If you want to join our community or just learn more about us, we encourage you to visit our website, www.ars-medica.org, and don't forget to subscribe to our YouTube channel. Thanks for tuning in, and until next time. Thank you, Rani.
Should I hang up? Are we done? Or
Yeah, I think Javier is going to wrap it up.
Okay, I'll hang out then.